Thank you very much for this invite to speak at your symposium. I've enjoyed and found many things to fascinate me over the 2 days so far. I think I'm going to be presenting experience rather than data, because this is at a relatively early stage as yet. Sorry, is that better?
Now it's better.
Yeah.
It's better,
okay.
Yeah.
And we've been using NIR's technology to illuminate the brains of our patients undergoing cardiac surgery for about 3 years now. I think in the process we've illuminated our own brains, and we've even illuminated the brains of some of our cardiac surgeons. I hope over the next 20 minutes I can share some of our experiences with you. I do have to declare that I have received expenses from the UK distributors of the FORE-SIGHT absolute cerebral oximeter in the UK, and that I'm also a principal investigator in the Oxicare study, which is a prospective randomised trial to test the effectiveness of cerebral oximetry to guide the care of adults during and after cardiac surgery. I apologise, I'm developing a throat infection, I think. So we provide cardiothoracic surgical services to an adult population of about 1.2 million. Our unit does about 1,200 cardiac surgical procedures per year. Our initial experience was with the INVOS, which is the Covidian product, and the NIRO, which is a Japanese product, with those two cerebral oximeters in patients undergoing ascending aortic or aortic arch surgery. But our more recent and most of our experience is with the FORE-SIGHT absolute cerebral oximeter in both aortic and in cardiac surgery. And we've now got experience of about 3,000 patients. The previous speaker has gone through very nicely the kind of scientific principles behind cerebral oximetry. It's a non-invasive technology. It continuously monitors regional cerebral tissue oxygen saturations at a microvascular level. It's based on near-infrared spectroscopy. As we've seen, and as the picture shows, NIR light will penetrate the scalp, it will penetrate the skull, and it's absorbed differentially by different pigments, specifically oxyhemoglobin and deoxyhemoglobin. And the number we obtain from the equipment reflects regional cerebral metabolism and the balance of cerebral oxygen supply and demand. We've seen the absorption spectra for hemoglobin, and the picture also demonstrates that NIR light will pass very easily through water and lipids, which make up the majority of human tissue. Again, each of the different hemoglobin moieties has its own specific absorption spectra. It's important to remember that when we're doing this, we're illuminating only a very small proportion of the frontal lobes, and we infer from that what may be happening elsewhere in the brain. Again, we're measuring oxygen saturations at a microvascular level, so at the level of arterioles, venules, and capillaries. It's been shown by various scanning techniques that blood in the brain is approximately 25% arterial blood and 75% venous blood. Again, it's this balance of cerebral oxygen supply and demand that we're looking at. So most of our experience is with the FORE-SIGHT absolute cerebral oximeter. As I think the previous speaker demonstrated, this uses laser technology and uses near-infrared light of 4 very precise wavelengths. The light is transmitted by a fibre optic cable. There are 2 disposable sensors, a single patient use only sensors that comprise a light source and 2 light detectors. As I've said, 2 channels so that we can look at both the left and the right side of the brain together. And the monitor will update every 2 seconds, so it gives you a very rapid response time. It has been validated. This is the validation that was performed in healthy volunteers, and I think you can see that this is the green line is the numbers we obtain from the FORE-SIGHT. The blue line is the numbers which are obtained from simultaneous jugular venous oximetry. So I think there is a pretty clear correlation with jugular venous oximetry. Sensors are placed bilaterally on the forehead, and as the previous speaker described, there's an emitter of light, essentially two pathways of light, one which picks up a signal from the superficial tissues and one which picks up a signal from the deeper tissues. that's what we see when we use this. So that's what we're seeing in theatre. At any one time, we see two numbers which reflect the tissue oxygen saturation from the left side of the brain and the right side of the brain. And we see a trend of cerebral saturations against time on the x-axis. The axis can vary anywhere between 30 minutes and 24 hours. So this is a patient having coronary artery surgery on cerebral CPB, a cardiopulmonary bypass. We start here with an awake patient. We put the patient off to sleep. We typically see this nice peak, very correlating with the time of laryngoscopy and intubation, which I think reflects a surge of arterial blood to the brain, consequent to the pretty significant hemodynamic stress that laryngoscopy and intubation provokes. We then have a period on before bypass, and here we've gone on to bypass, and you see typically that the cerebral saturations will fall. That's probably a consequence of a number of things. We're losing the pulsatility of blood flow. We're probably accepting lower mean arterial pressures. We're making adjustments to carbon dioxide tension. And there's a hemodilution effect because pumps tend to be primed with crystalloid solution. So we see that, and then we progress through the bypass case, and there's some ups and downs, as pressure changes, various other things change. And then at this stage here, there was an attempt to come off bypass, and we failed essentially in this particular case. There was significant bleeding, which resulted in a fall in pressure, a fall in oxygen supply to the brain, and this monitor picked it up very nicely. We had to go back on bypass. Things recovered. The surgeon did what he needed to do to correct the source of the hemorrhage. We then came off bypass again, struggled a bit, but then with fluid manipulation and inotropes, we're able to recover the situation. And there we have the post bypass period, where we start to try and put things right, improve the haemoglobin concentration and that sort of thing, and cerebral saturations improved. The previous speaker mentioned the fact there are a number of different oximeters on the market. The FORE-SIGHT over on the left, there's the Invos machine with which he'd had his experience. There's a Hamamatsu product, and there's a product called the Nonin. He also alluded to the fact that there are important technological differences between the different oximeters. The FORE-SIGHT employs laser technology to produce light, NIRS light of very specific wavelengths, less than what the spread of the wave is less than 1 nanometer. The other oximeters use LEDs, which have a very wide bandwidth to them of approximately 40 nanometers. The FORE-SIGHT uses 4 wavelengths. The other oximeters use 2 or 3 wavelengths. Consequently, you'd expect perhaps the FORE-SIGHT to be the more accurate machine, and I think that's, again, there is recent evidence that that's the case. This is data from the Hypoxia lab in San Francisco, where they've compared each of, in fact, 5 different oximeters and under controlled situation, and I'm in no doubt myself that supports the view that the FORE-SIGHT is the most accurate of the available oximeters at the present time. So my own experience started with ascending aortic and aortic arch surgery, and it's very obvious that if you're going to treat patients with pathologies like this and end up with surgical procedures like this, that you're going to impact upon cerebral blood supply and cerebral oxygenation. We basically have 2 methods to protect the brain when we're doing this sort of surgery. The first is our most common preferred method these days is to use selective antegrade cerebral perfusion, where we cool to 30 degrees. We have a period of lower body circulatory arrest. We pack the head in ice, and we perfuse the brain with blood at 30 degrees via a cannula sited in the right axillary or the right subclavian artery. The other occasional method that we use these days is deep hypothermic circulatory arrest, where we cool the body and the brain to 15 degrees. We pack the head in ice, we give thiopentone, we give steroids, and we accept a period of whole body circulatory arrest. So this is the first of the options. What the surgeon does is to cannulate the right subclavian or right axillary artery. And when we go on to selective antegrade cerebral perfusion, he places a clamp across the brachiocephalic artery, and we perfuse the brain via the right common carotid. There's also some flow going up the right vertebral from the subclavian artery. We rely on flow across the circle of Willis to perfuse the left side of the brain, but we know that that flow is non-existent in somewhere between 10 and 15% of patients. So this was actually the first case we did with the FORE-SIGHT. Prior to that, we'd been doing cases with the other oximeters or sometimes without any sort of neurological monitoring. This was an 84-year-old lady who presented with shortness of breath. She was found to have aortic regurgitation and a large ascending aortic aneurysm, and listed for aortic valve replacement and ascending aortic and aortic arch replacement. She went off to sleep, she went on to bypass, and we began the process of selective antegrade cerebral perfusion via the right axillary cannula. And you see very nicely that on the left side the saturations plummeted immediately. On the right side they were maintained. And that was corrected very easily by the surgeon. The aortic arch was open at this stage, so he could cannulate the left carotid artery. And we were able to very quickly resurrect the situation. But when this goes like this, it's really frightening. It happens very quickly. The monitor's updating every 2 seconds, and things start to drop like a stone, and you know that there's a problem. The patient made an uneventful outcome. More rarely we use deep hypothermic circulatory arrest. So this was a 42-year-old man. He'd had a previous aortic root replacement for an aortic root aneurysm, and he'd been shown on routine CT scanning. These patients get scanned at 6 monthly intervals. He had a pseudoaneurysm at the site of his distal aortic anastomosis. So he went on to bypass, he went off to sleep. He went on to bypass via cannulation of the right femoral vein and the right axillary artery. We cooled him to 15 degrees and we packed his head in ice. And this is the moment when we went on to circulatory arrest. And this is the typical picture of a patient who goes on to circulatory arrest, which isn't actually what I expected that we'd see when we started to do this. I assumed that we were depressing the brain with our hypothermia and our thiopentone, and we'd actually see the saturations rise, but we don't. And I think this is probably a reflection of the fact that there's no blood in the system, and any blood that is in the system actually drains from the frontal areas to the occipital areas during the process of no perfusion. And we've seen that several times now. So moving on from aortic surgery, what about the use of this technology in more general cardiac surgery? And there is developing evidence that falls in cerebral oxygen saturations during cardiac surgery do impact on outcomes. So we've been doing this now for about 2.5 years. It's used pretty much routinely on anyone having a cardiac surgery procedure in our hospital. And this is just an example from a patient having a transapical TAVI procedure. They started awake. We improved the saturations going off to sleep, which may have been a reflection of the fact they had I think this patient had relatively low systemic saturations due to respiratory disease, and when we corrected that under anaesthetic, things improved. Here's the period where we induced rapid ventricular fibrillation to balloon dilate the valve, and this is the period when to balloon dilate the native valve, and this is the period when we did the same thing to insert the new valve. So that's something you would expect to see, and the technology does pick it up. But it's also alerted us to many other things. This is one of the things it's alerted us to, I think, is to the fact that in general we just blindly hyperventilated our patients. They all went on to standard settings on the ventilator, and in reality we were overventilating them. And in fact we've noticed that very often there was a significant impact on the cerebral saturations that's picked up. This is just a slide to highlight that sort of thing. This is a young man who presented with congestive failure. His investigations revealed pericardial calcification and constrictive pericarditis, and he came to theatre for a pericardiectomy. You see we start here awake, we get that nice peak correlating with laryngoscopy and intubation, and then things settled to a level again, and then cerebral saturation started to climb, and this corresponded to the fact that the surgeon required us to hypoventilate the patient in order to obtain surgical access. So the saturations were very high, and then dropped precipitously when we went on to bypass, which was actually quite frightening at the time, you know, to see that, and then this is happening over maybe 30 seconds, that sort of decline. It was very reassuring to see the decline halted and then things improve on bypass. So just an example of the dramatic impact that carbon dioxide has on cerebral oxygenation. This patient is slightly more complicated. This was an old lady who presented with shortness of breath and found to have mitral valve endocarditis on a prolapsing valve. Staph aureus in a blood culture, treated with antibiotics, developed pulmonary edema, treated with high-dose diuretics, referred to us for a mitral valve replacement. When she came over, she was profoundly hypokalemic. She had a metabolic alkalosis and a respiratory acidosis. The picture highlights a number of things. She was awake at this stage. She went off to sleep. At this sort of stage was a profound drop here, which reflects, I guess, failure of anaesthetic technique. In fact, she'd been given some fentanyl and stopped breathing, and the cerebral saturation monitor picked that up. And it's often the case that this monitor will pick up problems before the pulse oximeter, which tends to have a much slower response time to it. But we corrected that, and there was quite a prolonged period pre-bypass. This is where we went on to bypass, and again there was a profound fall in oxygen saturations, which reflected the fact that in fact we went on full bypass, some blood was going through the lungs and the heart, and I think the brain was preferentially perfused with blood, which was actually finding its way through the lungs and then up to the brain. We remedied that, but the real feature of this case was it was extremely difficult to keep the cerebral saturations up all the way through bypass. And in fact, I realised subsequently that what we should have been doing is running a very high CO2 to put her back to the sort of CO2 that she'd had before she came to theatre. Often the problem we get is multiple problems which merge into one. So this is a lady who presented with an acute coronary syndrome. She was found to have severe aortic stenosis, 3-vessel coronary disease. She had an anemia which was investigated, but no one could find a cause, and she had bilateral carotid disease, but it wasn't particularly severe. She came to theatre for an AVR, a coronary artery surgery, went off to sleep. In view of her anemia, the perfusionists were very keen to try and prime the pump with her own blood, so one of the techniques for doing that is retrograde autologous priming. But the impact of that is that we make the patient more anemic and more hypovolemic. We can correct the hypovolemia with vasoconstrictors, but as soon as she went on to bypass, this anemic hypovolemic patient vasodilated and the cerebral saturations were immediately low. The whole thing was compounded by the fact that no one had told us that the blood fridge was out of action, so we had no blood to give this patient, which would normally have been the first step here. So the perfusionists persisted for a while with very low flows, which would be their normal practice, realised that we were in trouble, and decided to give more clear fluid, which had the effect of further lowering the haemoglobin, but allowing them to increase their flow. And as a consequence of that, there was an improvement in cerebral saturation. And then there was this second peak when the blood actually arrived from the blood bank, which is about a mile down the road, and we were able to transfuse the patient and get the cerebral saturations up to a stable number again. It's very good at picking up unexpected surgical events. This is a patient who was undergoing a mitral valve replacement, a tricuspid valve repair and a cabbage. It was an uneventful procedure until this happened. No one could work out why, but eventually the surgeon realised that the superior vena cava venous cannula had slipped out, that the snug tie had tied around the SVC. So there was actually no venous return from the head and the upper part of the body. And again, it was a cerebral oximeter that picked that up. It tells us about unexpected anaesthetic and perfusion events. This patient illustrates quite nicely two dips here. The first dip occurred when the perfusionist was distracted and went on to bypass without switching the oxygenator on. Again, the first sign that there was a problem was when the cerebral saturations dipped horrendously. This dip over here was anaesthetic related. The patient went into atrial fibrillation, and to get the internal paddles into the chest, we had to stop ventilating. There was then a problem because the defibrillator wouldn't discharge, and we got totally distracted by trying to remedy that and forgot that we were no longer ventilating the patient. Cerebral saturations fell. Again, it was this monitor that highlighted the fact there was a problem. Cerebral oximetry helps us to wean patients from bypass. This was an old man who'd presented with an infarct and a post-infarct VSD. He came to theatre with a balloon pump in. He was very high risk, but he had his surgery. This here is where we were coming off bypass, and we were about to fail. I was very worried we were going to fail and we were going to have to go back on bypass. But with fluid loading, inotropes and using TOE and that sort of thing, we were able to correct the hemodynamics and come off bypass successfully, and he did very well. It also tells us when we're not doing so well, and this was a patient, again, quite a high-risk lady who presented with an infarct, 3-vessel disease, quite a significantly impaired ventricle. She went off to sleep, she had a surgery. I think we came off bypass about here, and things just started to trickle away fairly quickly. About here, we had a cardiac arrest. We had to start cardiac massage. We'd given protamine, so we had to give more heparin and go back onto bypass, and things were restored on bypass. So, loads of anecdotes, but no actual proof that any of that makes any difference to patient outcomes. But I think there is evidence starting to emerge that if we use cerebral oximetry in cardiac surgery, we can impact on outcomes. And this is just the sort of algorithm that people are using. We monitor cerebral saturations. If things are low, we need to check that the head position is okay. We don't want the head over to one side. If we're on bypass, we need to check that the arterial and the venous cannulae are in the right place. If they're not, we replace them. We need to pay attention to very simple things. Is the blood pressure okay? Is the patient properly saturated? Is the PaCO2 okay? Is the haemoglobin okay? They're all simple things, but this alerts us to the fact that there may be a problem and maybe we should be doing something about it. So does this optimization of cerebral oxygenation make any impact on outcomes? Well, I think the evidence is that it does. This is evidence from Goldman, and what they did is look. This was a historical comparison. So they looked at large numbers. There were about 1,000 patients in each group, and they were able to show that they could reduce their stroke rate from 2% to below 1% if they used cerebral oximetry and attempted to optimize their cerebral saturations. They could reduce the length of the incidence of prolonged ventilation similarly if they did the same. Criticised, although it's a large study, it's a historical control group. This is Merkin's paper where he did similar things. And again, he was able to show that he could reduce his stroke rate from 4.2, which is a bit high, to 1.1. That was not significant statistically. But he was able to reduce a composite of major morbidity from 12.5 down to 2%, which was highly significant. Admittedly, only fairly small numbers in each of the group. I think there are many other potential uses of this cerebral oximeter. We can use it in carotid surgery, thoracic surgery, anywhere where we're putting patients' head up and making their blood pressure low, such as neurosurgery, middle ear surgery, shoulder surgery, patients with head injuries, perhaps in patients with carotid disease who need other surgeries, and probably many other applications of this. This was a patient I did who needed a carotid surgery, presented with cardiac disease, but required a right carotid endarterectomy. And here we pick up very nicely what happened when the surgeon clamped the right internal carotid artery. And again, what happened when he put a shunt in. So the technology tells you very accurately what's happening. Similarly, there was a bit of a dip, but less so on the left-hand side, which I guess is consistent with the fact that the patient had collateralized and the left side of the brain was getting a supply by other means. For the intensivists among you, this was we took a number of patients with swine flu just over a year ago now, because all the ECMO centres in the UK were full of these patients. This was a 21-year-old lady who presented with a short history of flu, become very hypoxemic despite all the appropriate ventilatory measures. She was H1N1 positive. She also had a pneumococcus in her blood culture. As I said, she came to us because all the ECMO beds were full, and we used veno-venous ECMO via right femoral and internal jugular veins. And that was her cerebral saturation trace from the moment she came to us and the moment the ECMO lines went in. What I found fascinating about this, which kind of tallied with what someone said earlier, was that her systemic arterial oxygen saturations at this stage were only about 60, which was similar to the numbers we picked up with the cerebral oximetry, which I interpreted as nearly finished, as showing that the brain will do everything it can to divert the oxygen that the body has to the brain. But she made quite a nice recovery with the ECMO and made a very successful recovery. Last slide but one. Complications we've seen are few. This was a man with with chronic liver disease who'd actually had a TAVI procedure. You can see that the sensors had marked his skin, but so had the pads we put on to protect his eyes, so had the tie for the ET tube. That's really about the only complication we've seen. In summary, I think that cerebral oximetry is now user-friendly technology that allows us at least to get a measure of cerebral oxygenation. We would regard it as a standard of care for anyone having aortic arch or ascending aortic surgery and any patient who's got shown to have flow-limiting carotid artery disease. In a more wider cardiac surgical population, undoubtedly it informs patient management and it detects adverse, unexpected events before any other existing mode of bypass or patient monitoring. The literature suggests that the routine use of cerebral oximetry and the optimization of cerebral saturations will lead to improved outcomes and to reductions in length of critical care and hospital stay. Final point, it is expensive technology at the moment. The machines are somewhere between 15,000 and 20,000 euros each. The sensors are disposable, single patient use, somewhere between 150 and 200 euros as ballpark figures. So like anyone else, we're going to have to prove that the benefits of doing this in a cardiac surgical population outweigh the costs. Thank you for your attention.